I would like to thank the organizing committee for inviting me to deliver this lecture on the radiological approach to acute abdominal pain in the obstetric patient. Imaging of pregnant women with acute abdomen presents with unique challenges to the radiologist. Apart from considerations of safety to the mother, the radiologist also needs to consider potential biological effects, if any, to the fetus, particularly when a modality with ionizing radiation is used, such as CT scan. The radiologist needs to balance risks from not performing the examination versus the benefit from the radiological examination to the mother, and at the same time minimize risks to the fetus. This may be achieved through various imaging strategies, such as using modalities without ionizing radiation. And if that is not possible, then a low-dose CT scan. These are the learning objectives from this lecture. That is to understand the roles of different imaging modalities and using the information to counsel patients. And also I'll be showing some commoner conditions that present with acute abdominal pain in more advanced pregnancies.
The causes of abdominal pain in pregnant women may be broadly classified as non-obstetrical or obstetrical causes. Putting aside the less serious causes of abdominal pain that is common in pregnant women, such as bowel distension from gas, constipation, and pressure from the uterus, one has to consider the conditions such as these listed. Under the non-obstetrical causes, we have those that result from gynecological sources such as the ovary, and this can arise from ovarian rupture, hemorrhage, or torsion. In the uterus, one of the common causes of pain is fibroid degeneration. Another cause is stretched round ligament, although there is no radiological criteria for round ligament stretching. Under non-gynecological causes, pain can arise from practically any structure in the abdomen, and this includes the gastrointestinal tract, of which appendicitis is a common cause. Another common problem are stones in the genitourinary tract. Another source of pain is the musculoskeletal system, which forms the abdominal wall. Under the obstetrical group, you have preterm labor, but this is usually a clinical diagnosis. The other conditions, such as abruptio placenta or subchorionic hemorrhage, may be visualized on imaging. Uterine rupture is a very serious complication, which I will elaborate later. HELLP, or hemolysis elevated liver enzymes, low platelet syndrome, may also present with abdominal pain.
If you go to the ACR website, you will be able to find a set of guidelines or appropriateness criteria for imaging and application of the appropriate imaging modality for specific clinical problems. There are two tables set up for under acute pelvic pain, which is also applicable to abdominal pain for pregnant women. And the list here sums up the approach or the diagnostic approach for the diagnostic workup. Ultrasound is often the first modality of choice for most conditions. If ultrasound does not provide the answer to the clinical problem, then MRI, unenhanced MRI, may be used as the problem-solving tool. If MRI is not available and we are faced with a life-threatening condition, then one may consider using a low-dose CT scan. Ultrasound is usually the main modality of choice in the workup of obstetric problems from first trimester to the time of delivery. It is also useful for assessing gynecological causes of pain, such as degenerating fibroid and ovarian accidents. Whilst it is also effective for diagnosing non-gynecological or non-obstetric causes of pain. It is less sensitive, particularly in the later part of pregnancy, for assessing such conditions. It can be used to detect free gas in the abdomen. MRI is increasingly recognized as a problem-solving tool. Due to the uncertainty of safety of gadolinium-based contrast agents, it is generally not recommended. So contrast is usually not recommended unless absolutely necessary for diagnosis. And MRI is used more often in the later stages of pregnancy. While counseling and informed consent is usually not necessary for ultrasound, it is often used in patients who are going for MRI or CT scan. In such instances, patients should first be informed by the clinicians about the imaging. And referral information, that means information that's given to us, should be sufficiently detailed so that we can tailor the studies according to the patient's needs. And the radiologist's role is to provide clear and simple information to the patient on the risks and benefit of the imaging study when obtaining consent from them. And this is particularly important for studies involving ionizing radiation. One approach to address fear from ionizing radiation is to make reference to the year-long background radiation that we are all exposed to, and also the exposure from other activities such as air travel. Let's do a bit of revision here. So let us ask ourselves this question. What is the fetal radiation dose below which there is negligible effects from non-carcinogenic risks such as malformations and pregnancy loss based on consensus? Is it 200, 250, 100, or 50 milligrays? The answer is 50 milligrays for deterministic effects, that is all or none effects. In addition, the NCRP also states that the risk of malformation is significantly increased above control levels only at doses above 150 milligrays. Therefore, exposure of the fetus to radiation arising from diagnostic procedures would very rarely be caused by itself for terminating a pregnancy. Similar policies were then adopted by the American College of Radiology and American College of Obstetrics and Gynecology. This table shows the effects on the conceptus based on various stages of pregnancy and the estimated threshold radiation dose that can cause the anomalies. The fetus is at risk for teratogenesis, especially during the period of organogenesis, that is between 2 weeks to 15 weeks of gestation, and especially during the 8 to 15 week period. However, to put things in balance, we can also see that the threshold dose is quite high in order to result in such defects. This table shows the typical radiation doses from different examinations. From this table, we can see that most of the radiological procedures have radiation dose that fall below the threshold. And even for the studies of concern, which is the CT abdomen and pelvis, you can see that actually the dose still falls within the below the threshold. Apart from deterministic effects from ionizing radiation, one also has to consider its stochastic effects, which can result in carcinogenesis. Unlike deterministic effects, stochastic effects do not have a threshold, and the probability of such effects depends on the dose as shown in this table. It is important to note when counseling patients that there is a background risk, even without
in even in the absence of any radiological examinations. In patients who have received the threshold dose of 50 milligrams, the risk of childhood cancer increases by 0.42%, and that is an excess of 4 individuals in 1,000.
Based on available data, most professional bodies, including the ACOG, has similar stance on the use of radiological procedures involving ionizing radiation. So it is stated here that if these techniques, meaning the CT scan or radiography or nuclear medicine techniques, are necessary in addition to ultrasound or MRI, or are more readily available for the diagnosis in question, then such procedures should not be withheld from a pregnant patient.
Let's have a look once more at the causes of abdominal pain in pregnant patients. They can be broadly classified as obstetrical and non-obstetrical causes. This is the ultrasound protocol that we use in my department for patients who present with abdominal pain during pregnancy. Scans are done on the pregnant uterus to assess for signs of fetal life. We also look at the uterine contour to see whether there's any irregularity, especially in patients who are suspected of having a rupture or dehiscence. We also examine it for presence of any masses, such as uterine fibroids. Then we look at the placenta to see whether there's any hematoma or hemorrhage. We also assess the adnexal regions for presence of masses or free fluid and signs of inflammation or any focal tenderness. For patients with other areas of pain, we do a general survey of the abdominal organs, similar to that of an abdominal ultrasound. Then we may also do a targeted approach for specific conditions, such as appendicitis. Pain from degenerating fibroid is common, and this can be easily diagnosed with ultrasound. The pain is usually localized to the fibroid, and on probing it with the transducer, you can actually elicit tenderness over the fibroid. There may be cystic changes within the fibroid. However, fibroids that have undergone calcifications are usually no longer painful.
This is a patient who came to us at 25 weeks of pregnancy, presenting with abdominal pain and vomiting. As you can see from the MRI, she has twins. In the CT scan shown on the top right-hand corner, we know that she has also a right dermoid cyst that was previously diagnosed 12 years ago. The ultrasound, which is shown here on the left top-hand corner, is that of an echogenic mass that corresponds with the dermoid cyst. However, the question from the clinician was whether she had ovarian torsion or appendicitis. As there were no features of ovarian torsion on the ultrasound or MRI, we had to look for the appendix, in this case, which is shown here, tucked under the uterus in the right flank. And this case illustrates that it can be very challenging to look for the appendix with ultrasound.
According to ACR appropriateness criteria, ultrasound with graded compression is still the first-line imaging. In order to displace the enlarged uterus, the patient may lie in the left posterior oblique or left lateral position. As shown in this diagram, the position of the appendix changes during pregnancy, and as the pregnancy advances, the enlarging uterus displaces the cecum and the appendix towards the right upper abdomen. Finding the appendix becomes more challenging as pregnancy advances. In up to 88%, ultrasound may fail to demonstrate the appendix, and hence MRI is recommended in negative or equivocal cases. MRI has a 100% negative predictive value. On MRI, the normal appendix has an appendiceal diameter of 6 millimeters or less, wall thickness of 2 millimeters or less, and low T1 and T2 intraluminal signals. There should not be any periappendiceal fluid or edema. This is our MRI protocol for appendicitis in KK Hospital. We have two basic imaging sequences, that is the coronal T2 images with and without breath holding of the whole abdomen. And then we perform a T2 axial sequence with and without fat saturation centered on the cecum. If necessary, we also add in the sagittal T2 images. This is a coronal T2 section of a normal appendix showing its normal low signal. This is an image taken from the literature of a case with appendicitis. As shown here, the appendix is distended with high signal fluid. There is an appendicolith, which is causing the obstruction. Periappendiceal fluid is also noted. Appendicitis is diagnosed on MRI if there is a diameter of the appendix exceeding 7 millimeters, wall thickness that is exceeding 2 millimeters, there's high signal in the intraluminal contents, and presence of any periappendiceal fat stranding and fluid. In patients who have a borderline measurement of the appendiceal diameter, say around 6 to 7 millimeters, with presence of high signal intraluminal contents but no other signs, these patients should be considered as indeterminate for appendicitis, and further monitoring is required.
Shown here is a patient who presented with severe right lower quadrant pain, and as you can see from this video clip, there is an area of increased echogenicity in the right side of the abdomen. Okay. This is another image showing the increased echogenicity and site of maximum pain. There is increased vascularity in the region.
Although one could see from the ultrasound in the previous slide that there were signs of massive inflammation, the actual cause was not readily apparent. And quite often, MRI is requested by surgeons to further delineate the lesions before surgery. This is the MRI performed on the patient. As can be seen here, there is a mass in the right lower quadrant, and the patient here is in the first trimester of pregnancy. This image is the fat saturation, which shows the collection in which gas can be seen within the collection. There is a thick wall surrounding the collection, indicating a chronic abscess, and this was due to a ruptured appendix.
Ureteric calculus is another cause of abdominal pain, and ultrasound can be used to make a diagnosis depending on the location of the calculus. In this patient, the calculus could be seen in the at the uretero-vesical junction, as shown here as a small echogenic focus with shadowing. This is the fetus over here. Okay. The calculus at the lower end of the ureter can also be shown on transvaginal approach, as seen in this journal. However, it is not always that easy to diagnose ureteric stones during pregnancy, as the ureters tend to be dilated during pregnancy, and this can cause a bit of conundrum in the diagnosis. That would be a topic for another lecture.
The next patient presented in mid-trimester with acute abdominal pain. Shown here on ultrasound is an echogenic mass. This is the fetal head, which lies within the uterus above the cervix. This is the placenta, and the mass is actually outside of the amniotic sac. Subsequent follow-up on MRI confirms our suspicion of the subchorionic hematoma, which is shown here. In addition, there was also this structure which we didn't really know the cause of, but subsequently found that this was due to a demise twin and that occurred earlier. So putting the two together, we think that this is probably the cause for the hematoma. Subchorionic hematoma that we've just seen is not so common during the later part of pregnancy. It is more commonly seen during the first trimester. The hematoma collects between the layers of the uterine wall and the chorionic membrane. Bleeding may be silent. However, large hemorrhages may result in placental separation or placental abruption, and this increases the risk of pregnancy loss.
This is a patient in the first trimester. As you can see here, within the white arrows is the subchorionic hematoma. The embryo is still alive. Okay, we could detect cardiac pulsations.
This is a patient who was undergoing mid-trimester termination of pregnancy when she developed abdominal pain. The ultrasound showed that the fetus was lying outside of the uterus, and there was no cardiac pulsations, indicating that it was non-viable. There was suspicion of uterine rupture. The patient subsequently underwent CT scan. I guess there was a question of whether this was a ruptured uterus or an intra-abdominal pregnancy. As you can see from these images, there is hemoperitoneum, and within the pelvis one can see that the fetus actually lies in the left side of the uterus. That's the fetus, and there is disruption of the uterine wall, indicating the ruptured uterus. In uterine rupture, all layers of the uterus are disrupted. This is a potentially life-threatening event for the mother and fetus. Women with prior cesarean section are at risk of this complication, and the incidence is around 325 per 100,000 who are undergoing trial of labor. Other causes include prior surgery to the uterus, such as myomectomies, patients who have obstructed labor, or placenta accreta. Swift et al. Found that in women with a lower uterine segment thickness of more than 3.65 millimeters have a lower likelihood of uterine rupture. This is based on a systematic review and meta-analysis of 28 observational cohort studies.
As the caesarean scar is not easily identified, the ultrasound measurement for the lower uterine segment thickness is usually performed at around the estimated site behind the bladder dome, as shown in this image.
HELLP, or hemolysis elevated liver enzymes and low platelets, is a rare condition, occurring in about 4 to 12% of patients with severe preeclampsia. Patients may present with nonspecific abdominal pain, right upper quadrant pain, and abnormal liver function tests. In more severe cases, there may be liver infarction and rupture. Imaging may reveal hepatic edema, ascites, pleural effusion, and hepatomegaly. On ultrasound, infarction may be seen as an area of increased echogenicity. However, this mimics fat infiltration, which is sometimes seen in the third trimester of pregnancy. On CT scan, which is a little bit more specific and accurate, infarctions or infarcts in the liver may be seen as well-defined hypodense, non-enhancing areas or multiple peripheral wedge-shaped areas of low attenuation. On MRI, both intra and extrahepatic hematoma may be visualized, as well as hepatic necrosis. The signals depend on the degree of hemorrhage, necrosis, and steatosis.
Apart from the liver, complications can also be seen in other structures, and this may occur in the form of disseminated intravascular coagulation, abruptio placenta, renal failure, pulmonary edema. And the treatment for HELLP is expeditious delivery of the fetus. Here are a couple of examples of the type of complications that can occur with HELLP. On the left is a CT scan of a patient showing multiple infarcts in the peripheral aspect of the right lobe of the liver, as shown by the yellow arrowheads. This patient also has subcapsular hematoma, as shown here, and the spleen is also enlarged. On the right is a T1 weighted coronal image of the liver, showing a large hematoma which is displacing the liver. There is increased risk of venous thromboembolic events in pregnancy. While most of these events occur in the lower limbs, venous systems in other parts of the body may also be affected, including those in the abdomen. And they include the pelvic venous system, hepatic, mesenteric, and gonadal venous systems. Although rare as causes for acute abdominal pain, assessment should also include these structures, particularly if there is clinical suspicion and if these structures lie in the field of the imaging. In imaging the pregnant woman, it is important to differentiate between pregnancy and non-pregnancy related causes of pain. Ultrasound is useful as a first-line imaging modality in diagnosing pregnancy as well as gynecological causes of pain. It is also recommended as the initial imaging modality for a number of non-pregnancy related conditions such as appendicitis. In cases where ultrasound is unable to provide the answer, then MRI may be used as a problem-solving tool. On the other hand, CT scans and other X-ray procedures should not be withheld if clinically necessary. In such instances, counseling on risks and benefits should be done to allay fears of X-ray in the pregnant woman. With that, I thank you for your attention.